Good morning to all. Welcome to IC21 Infectious Uveitis and Scleritis Battle Against the Bugs. We have got 7 speakers. Seventh one, infectious scleritis. Dr. Mamta Agural is not there. So you people can relax and take 10 minutes up to. And we have got 19 minutes discussion. And before that instruction course starts, the AIOS instruction as per, we will be having a keynote address by Dr. Sheikha Noda Ali Kosemi, who will be talking on uveitis, basic infectious uveitis. Dr. Kwashimi, please.
And how can hear? Okay. Thank you so much. Good afternoon, ladies and gentlemen, dear colleagues. Thank you for inviting me as a speaker. Congratulations for the 81st edition of the All India Society of Ophthalmology. Thank you for the great work, the scientific and the steering committee. Today I'm going to have to start this session, uveitis session, with a classification and overview in uveitis as a nutshell. So what is uveitis? It is an inflammation of uveal tract, not only limited to the uvea, but can also involve other ocular structure such as retina, vitreous, or optic nerve, and sclera. There are different presentations of inflammatory eye diseases, and
slides are not seen.
Oh.
Slides. Slides is not shown. Yeah.
Yeah. So the inflammation, uveitis is the inflammation of uveal tract, not only limited to the uvea, but can also involve other structures such as retina, vitreous, optic nerve, and sclera. Different presentations of inflammatory eye disease when the patient presents, whether ER, referral from an ophthalmologist, or even referral from other dear colleagues from other specialties. So there is a great working group called Standardization of Uveitis Nomenclature SUN Group. This is an international expert committee which follows the aim to develop this as standardized and internationally recognized terminology for the field of uveitis. So as a uveitis specialist, we talk same language, and this made us pave the road for diagnosis and even discussion among colleagues. For example, a description of uveitis. As an onset, we have a standardized terminology, whether it is sudden or insidious. The duration, if it's less than 3 months, it is limited. However, more than 3 months, persistent. The course of the uveitis in general, whether it has been categorized as acute, recurrent, or chronic. Again, SUN has worked also as an anatomical classification. We are not only uveitis, we are detailed of sub-uveitis. We need to have a clearer mind map, and SUN has been classified as per the anatomical classification. Anterior uveitis, where the site of inflammation is in the anterior chamber. Intermediate uveitis, where the vitreous is the site of the activity. However, the posterior uveitis, retina, or choroid. Overall, the 3 layers if the activity is involved, such as AC, vitreous, retina, or choroid, it is panuveitis. And even this is a well-known diagrammatic, has been published or worked by SUN. We are not only uveitis or doctors, we are also investigators. We follow like Sherlock Holmes, that we have a very low threshold. So we ask for the patient as a detailed questions, the duration, exposure of whether this is a trauma, just to have, it's not a usual redness post-trauma, could be sympathetic ophthalmia, photophobia, whether this is, this also add a lot to our diagnosis, changes of vision, reduction in acuity, halos, visual disturbances. This is also as leading us to differential diagnosis, discharge, because a lot of patients, they've been underdiagnosed by uveitis simply because the family physician or general practitioners, they diagnose as conjunctivitis. Past ocular history, previous episodes, previous herpetic eye disease, previous eye surgery. Nevertheless, we are investigator. We investigate and review of system from top to toe. So those great lists, this is as our putting in our every new patient, we have a detailed, thorough review of system, like respiratory for TB, sarcoidosis, GI for inflammatory bowel disease, and which is really common among our population, musculoskeletal for the like GIA or HLA-B27 related arthropathies, skin for Behçet disease, sarcoid or psoriasis, CNS as an MS. Why it is important? Because when we correlate those classification anatomical, this will guide us also that systemic manifestations in the body, really there is a strong correlation in initiating uveitis. So HLA-B27, it's well known for anterior uveitis. MS is for intermediate. Posterior, there are a lot sub inflammations, retinitis, whether focal or multifocal, and well known also diseases which cause focal or multifocal choroiditis. And nevertheless, there are well known diseases for causing panuveitis. International Uveitis Study Group has categorized or classified uveitis as the relating causes: infectious, which we are going, this is the session is all about, non-infectious, and masquerade. We are not only doctors, we are not only investigators, we are also divers in oceans. Why I'm telling that? Going to our investigation, examining now the patient, we are grading the AC as a flare, and cells, and we have to take a long time and being patient just to evaluate and appreciate how many cells in general in an AC. Nevertheless, even in the vitreous as a haze, and we grade it accordingly. Investigation is important in diagnosis, management, and follow-up, such as OCT, fluorescein angiography, ICG for choroidal disease, electrodiagnostic tests, and visual field. And this is, I'm not going to talk about the investigation because it needs another one session. And we are a puzzle expert in a sense that after having the examining the patient thoroughly, taking a proper history, and doing the accurate investigation, nevertheless, there are certain blood work and chest x-rays needed, and there are like a baseline and selective. So we are just collecting the information and applying it on our mind map and for the next step forward. So we have to complete the puzzle in order for the diagnosis with the investigation, so we can tailor the management. Also, if we are clueless and there are such important and non-resolving the activity, or it's getting worse, or it is not improving with the management, our initial management, it's not shame to step backward, revise this, the study, the case itself, discuss it with our colleagues, and we can have another top-up investigation, and this is also an important to be discussed today. For intraocular fluid samples for infectious, as a viral, bacterial, parasitic for Toxoplasma gondii, fungal for Candida, and also as a masquerade to make sure that this is not a lymphoma, so we take fluid sample. There is a great study in the Ocular Immunology and Inflammation Journal, a focus of the epidemiology uveitis, and it shows that it is around idiopathic is the most common form of uveitis. However, infectious causes are common 30 to 60% in the developing countries, like herpes, Toxoplasma, TB, syphilis. However, in non-infectious uveitis, conditions are generally more common in the developed country. Again, talking now, going deeply into the infectious uveitis, when we know that it is one of the main causes in the developing countries for uveitis. There is a study in 2016 saying that uveitis due to infectious etiologies account for between 15 to 20 cases in the United States. However, it may likely account more in a significant proportions of uveitis worldwide. So what are the infectious uveitis in general? And our dear colleagues and experts are going to talk later on. Bacterial, parasitic, viral, such as herpes, HIV, fungal candida, and not to forget that we need to, as an ophthalmologist or a uveitis specialist, not to underestimate, and we have to teach our colleagues, residents, trainees, and fellows that we need to always dilate the patient. Why? Because a dilated fundal examination is absolutely mandatory in every case of anterior uveitis. Remember that viral retinitis, which we are going to talk later, can cause blindness within days, and they can be mistaken for a non-infectious anterior uveitis. Of dilated exam is a mandatory, and if it's not performed. Even if the vision of the fundus is haze and not clear, we have to rule out if there is any presence of white or yellowish lesion, which denotes retinitis or choroiditis. And if you cannot be sure, I always stress this to my residents, to do ultrasound just to rule out how the vitreous is inflamed or how severely is inflamed. So this is why we dilate every patient. We presume that it is really healthy macula. However, if we miss the periphery. So we are not an ophthalmologist. We are not only divers. We are not a puzzle expert, or we are even an investigator. So we are not only to discover. We follow the steps. Thank you so much for the presentation and listening to me. And on this podium, I'm inviting you all to attend our Emirates Society of Ophthalmology conference in February 2024 in our beloved capital, Abu Dhabi. Thank you.
Thank you, Dr. Kasemi, for giving an overview of uveitis. We'll go to the questions at the end of the session. We have got about 19 minutes discussion time. Next is viral anterior uveitis. Is Dr. Somshila here? Yes. Yeah. Dr. Somshila Murthy from LVPI, and now is Bombay. We'll be talking on viral anterior uveitis practical tips. 8 minutes.
Good afternoon, everyone, and thank you very much for including me in this session, Dr. Biswas. I'll just try to take you through a few practical tips that I've learned over the years, how to manage the cases, how to recognize these cases actually. So I'm just going to go over some of the common viruses, and this is a mixed spectrum in the sense that the same virus can also cause endothelitis. Some of us, if you're anterior segment specialist, you like to call keratouveitis, or sometimes they can cause anterior uveitis, which can come in a 2 or 3 different clinical spectrum, because some of these cases can look just like Posner-Schwarzman syndrome. So that is the entire clinical spectrum of viral anterior uveitis, including the cornea, as well as can also have secondary glaucoma. So therefore, differential diagnosis from other entities becomes important. So I'll go through some cases and maybe less time for management in this particular forum. So the common viruses that can cause viral anterior uveitis include, of course, HSV type 1, then varicella zoster virus, and cytomegalovirus. These are the top 3, and we know about them. Probably they cause about 80% of all the cases. Rubella virus, I've put it up there because, as you know, that rubella virus is implicated in Fuchs heterochromic disease. And then there are a whole bunch of rare viruses. I think the more we explore, the more the previous speaker talked about diagnostic testing, the more we do PCR, we might find some of these viruses in some of our cases. And we know that we had chikungunya and endemic here earlier. So these are viruses that keep coming in. So let's just go to the common 3 causes of viral anterior uveitis, or I've just used a broad name of viral anterior uveitis, though it might include endothelitis, trabeculitis, and so on. So we have the broad 3 are HSV, VZV, and CMV. It's good to know how to manage these 3 cases because you can manage most of your 85–90% of the patients if you know how to recognize these. So if we quickly go through, how do we differentiate between the three? So in all three cases, you'll have anterior uveitis, of course, but in the patients who have more of a picture of HSV, you can have past history of recurrent keratitis. That's what I've shown here, this haziness in the corneal stroma. They can have corneal scars or hypoesthesia, that is reduced corneal sensation. You can even have dendrites at a previous visit. Everything doesn't happen at the same visit, but you may have past history of HSV on the cornea. And in this case, when the patient presents with the uveitis component, you might have KPs, which are small to medium, usually located in the site of the endothelitis. And there'll be moderate AC reaction, and the pressures may be high in the 30s or even 40s. So these are how you will distinguish that this is most likely to be HSV, keratouveitis, or endothelitis. On the other hand, how do you differentiate VZV? So it can happen in immunocompromised patients, but it can also happen in immunocompetent. The difference here is that you will have very large keratic precipitates, almost mutton fat looking. Typically, it will be unilateral. That's how you'll differentiate like a bilateral granulomatous uveitis from a unilateral granulomatous where it can be viral. And you will have this hypochromic patches or loss of iris pigment in areas, segmental iris atrophy, through which you can have transillumination. And these are very classic cases. And this is how you will have a patient. Sometimes patient might have H0 also. But when you have patients coming in with this kind of picture, you can think of VZV. Luckily, the treatment for HSV and VZV is practically the same. So management, you pretty much cover about 70% of your viral keratouveitis by knowing how to manage these patients. So then what about the third entity, that is CMV endothelitis? You know that CMV can cause retinitis, but this is very different from the retinitis. The immune deviation is different. So here you can have some corneal edema. There'll be typical coin-shaped, so-called coin-shaped KPs, or they can be linear KPs or granulomatous. So for me, it is if I have a patient of long duration anterior uveitis recurrent with secondary glaucoma and very minimal inflammatory signs. So the first virus I think of is CMV. And if I have the same kind of patient, but very classical signs, more inflammation, then I think of either HSV or VZV. But in my experience, and also in some of the published studies, the AC, the intraocular pressure is probably the highest with CMV. So it goes up to 40s, 50s. And you can have reduced specular count. So this is very typical for CMV. Being a cornea specialist, I do specular counts for all the patients. And in HSV, except for rare cases, which are very poorly treated, you will not really have the endothelial cell counts being affected during active disease. But in CMV, even with the inflammation appearing minimal, you will have the endothelial cells appearing distressed. So this is a very good clue for us to know whether it is CMV versus the other two viruses. What is important is because for CMV, we need to give, the treatment has to be different. So just rolling through a few cases, this is a patient who was a 38-year-old, had recurrent low-grade uveitis, and the patient came in with 16-year history and had secondary glaucoma as well. So because everything else was ruled out, but for some reason people were not thinking of viral, or even if they did, they were treating with acyclovir. So that was missed out. So we did an AC tab just to get evidence, and we got CMV bug in very high titers, started the patient on valganciclovir, and the patient improved remarkably. You can see corneal edema has gone down, pressures settled, although the patient did need a trabeculectomy. So this is at entry level, that's what the specular counts look like. This is after the edema had settled a little bit. And then after that, of course, the endothelium is distressed, but it has been stabilized. This is another case who a patient was HLA-B27 positive, just to confuse everyone, but had the similar history like the previous patient. So here you can see this corneal edema and some few keratic precipitates, and the patient just kept on having this problem till we did a PCR and we could again detect CMV and initiate therapy with valganciclovir. This is the acute phase where the patient has endothelial, both corneal edema as well as those folds on the decimase membrane. And finally, the patient again required a trabeculectomy surgery. And after treatment, the patient improved and has no recurrence after that. On the other hand, if you have HSV, So these patients can even have a hypopion because of the long-standing nature and untreated nature. This was a child, so we didn't suspect that it could be HSV. In fact, thought of retinoblastoma and malignancy for this child. Did an AC tap, and we could isolate the giant cells, but typical giant cells in this particular patient. And the patient again did well, but then developed a cataract and required cataract surgery. At least got relief from the inflammation. And my fourth case was another presumed HSV anterior uveitis. Everything was negative. So whenever we would start treatment, there would be improvement. But once we stopped treatment, the patient would come back with corneal edema. So in other words, the patient, it's not easy for every patient to behave like the textbook. You start treatment, but you can still have recurrences because there is an interaction between the infectious component as well as the immune-mediated component. So not to go into much detail, but you do need topical steroids to some extent, but very rarely do you need anything oral. You don't need oral steroids, you don't need oral immunomodulators to settle these patients. And I'm actually going through this because I wanted you to again welcome you to the annual USI meeting, which is going to be in collaboration with the EUVRE, the Vitreoretinal Society of UAE, and this is going to be very exciting. It's in Abu Dhabi, which is a lovely place to visit. And for budding young ophthalmologists, uveitis specialists, there are lots of travel grants as well to support funding. A lot of countries are participating in it apart from many of us. And this is a beautiful country with lots of things to do. So I encourage all of you to come and attend this meeting as well. Thank you very much. Thank you, Dr. Pata.
Thank you, Dr. Somshila, for giving an overview of viral anterior uveitis and practical tips. We'll have the questions at the end. Next talk is viral retinitis, emergency in uveitis, by me. Ten minutes. 10 minutes. I'll be talking on viral retinitis, which is an emergency in uvea practice. Let me start with a case. This is a 30-year-old female, immunocompetent. And if you look at the macula, you could see that there is a necrotizing retinitis lesions with hemorrhages. What is your diagnosis? You don't have to look into the diagnosis much, but if you look at the patient as a whole, you can get a significant clue. There is a vesicular rash of herpes zoster on the forehead. And this patient actually had varicose zoster retinitis, very unusual manifestation. And this patient responded dramatically after IV acyclovir for 7 days. So it was published. So in fact, viral retinitis is not only have varied manifestation, often vision threatening, requires prompt treatment and prompt diagnosis. It can occur both immunocompetent and immunosuppressed. Immunocompetent patients can have acute retinal necrosis. Rarely, immunosuppressed patients can also have acute retinal necrosis, can have HSV retinitis, HZB retinitis, rubella retinopathy, chikungunya, and dengue. Immunosuppressed patients exclusively have HIV retinopathy, CMV retinitis, progressive outer retinal necrosis, and rarely acute retinal necrosis. I'll start again with a case. He's a 42-year-old male, sudden dimness of vision for 1 week, diagnosed as chorioretinitis elsewhere. If the vision in the left eye was hand movement due to the previous chickenpox infection, right eye was 6, 18, and 12. Anterior segment was quiet except few pigments on the anterior surface of the lens. And if you look at the fundus, it has got very typical phenotype, characteristics wedge-shaped lesion with retinal vasculitis, vitritis, and little papillitis. What is your diagnosis and what test you will do? The diagnosis is quite obvious with this phenotype, acute retinal necrosis, peripheral necrotizing retinitis. What is acute retinal necrosis? It's a kind of a necrotizing retinitis occlusive retinal vasculitis, and vitritis, triad of the three. And what test we will do? Serology for other viruses are useless except ELISA for HIV to rule out underlying HIV infection. And what the patient requires is the anterior chamber tap or vitreous biopsy for polymerase chain reaction. And this should be done for the nested and real time for herpes simplex type 1, type 2, varicella zoster virus, and cytomegalovirus. Virus cannot be cultured easily and it takes a long time. So, polymerase chain reaction is the right way to go. And in fact, is the ACTAP or PCR for HZB was positive in this case. So, it is an emergency in uvea practice and it causes usually varicella zoster virus, rarely HSV1, HSV2, cytomegalovirus, and recently Epstein-Barr virus has also found to cause viral retinitis. Anterior segment acute anterior uveitis can be sometimes associated with it. Raised intraocular pressure is often quite characteristic and vitreous cells can be seen. And this is typical wedge-shaped retinal lesion, peripheral necrotizing retinitis involving the almost 360 degree in the periphery and retinal vasculitis. One can have retinal detachment and very typical of having large atrophic retinal holes. And this is a breaks which is seen in a case of acute retinal necrosis. They have got such a characteristic clinical pictures can be diagnosed easily, but can mimic sometimes CMB retinitis, syphilitic retinitis, toxoplasmosis. One of the conditions which I have seen missed by some other people like peripheral serpeginoid choroiditis. This patient was thought to be acute retinal necrosis, but if you look carefully, the lesions is deep in the choroid and there is a central area is clear. And this is actually a peripheral serpeginoid choroiditis which responded well with steroid. So, rapid circumferential spread over 7 to 10 days makes it an emergency. Fellow eye involvement 33% cases. Retinal detachment common in untreated cases, sieve like peripheral retina, multiple atrophic holes. They require medical treatment urgently, sometimes laser photocoagulations and surgical. And intravenous acyclovir is the common modality of the treatment. I give 500 milligram every 8 hourly for 7 to 10 days. After 48 to 72 hours, oral prednisolone 1 to 1.5 milligram per kilogram of the body weight. HIV positive patients add antiretroviral therapy. How long to give the IRN treatment medically? Is the minimum 3 months. Nobody knows that how long it should be continued. You should give oral acyclovir 800 milligram 5 times daily or oral val acyclovir 1 gram 3 times per daily and taper oral steroid gradually. And this is a case which I have shown to you, and within 3 days there is a significant resolution of inflammation, and day 8 there is a maximum resolution of inflammation, and after a month there is a complete resolution of inflammation. What's new is the oral antiviral therapy. It should be given in high doses, 1 to 1.5 gram 3 times per day. And photocoagulation is controversial. Some people do it as a prophylactic laser photocoagulation to create new ora serrata. The vitreous surgery is often required because they develop dense vitreous opacity, vitreous membranes, and retinal detachment. Diagnostic vitrectomy can be done when the ACTAP is negative and where there is a strong suspicion of viral retinitis. Vitrectomy, endolaser, and there should be always silicone oil tamponade. And here is a picture showing the vitrectomy. Unfortunately, that only 45% patients only had good visual recovery. 55% patients doesn't have much good visual recovery. Now shift gear to a immunosuppressed patients which developed exclusively CMB retinitis. We studied in the ocular lesion in 100 consecutive patients, and this is 8th era, and found 17% patients had CMB retinitis, which is the most common ocular lesion. This can be seen in the organ transplant patients or the patients with cancer therapy, cancer chemotherapy, and their picture is very characteristic. So once we have seen one case of CMB retinitis, we may not miss again. It is a dry granular whitish patch, necrotizing retinitis with hemorrhages, perivascular distribution, and so often takes up a pizza pie appearance. And this is the posterior pole involvement, nasal quadrant, perivascular distribution, and can be isolated peripheral lesion. and can involve the multiple quadrants, can have the frosted branch angiitis appearance. And if you don't treat it, it goes to the atrophy of the optic nerve and the thinning of the retina. The treatment is the intravitreal ganciclovir and oral valganciclovir. The implant and intravenous injection is no longer adopted now. Ganciclovir is 2000 microgram twice weekly induction and 2000 microgram once a week maintenance. And the high dose of intravitreal ganciclovir can be obtained by the intravitreal ganciclovir. Oral valganciclovir is a new alternative for treatment, good viability, avoid the risk of local complication at the infusion site. This is a 450 milligram tablet, 2 times daily till the resolution occurs. Retinal detachment requires plasma vitrectomy, silicone oil tamponade, with retinal detachment can occur 33% of the cases. Now, coming to the progressive route of retinal necrosis, fortunately it is rare. There is no anterior chamber or vitreous reaction in this case, no vasculitis, but there is optic nerve involvement. Poor response to treatment can be associated with the varicose zoster virus relationship. We have described in CMB also. Severe multifocal, deep, dense retinal necrotic lesion without vessel involvement. And it mimics a acute retinal necrosis or cytomegalovirus retinitis. Rheumatogenic retinal detachment is quite common. Papillitis or neuroretinitis. 85 to 100% patients present with the unilateral disease progress to have bilateral involvement. CDC guidelines say that the uveitis 10 milligram 8 hourly combined with the foscarnet, very poor response, retinal detachment, poor response to antiviral therapy. Toxoplasmic retinochoroiditis can mimic viral retinitis, and here is a case which was thought to be CMV retinitis and was treated with the antiviral treatment, ganciclovir therapy, did not respond. Retinochoroidal biopsy was taken, and retinochoroidal biopsy showed Toxoplasma gondii cyst. And this is last is the post-fever retinitis. It can be dengue, chikungunya, typhoid, rickettsia, chickenpox. But I don't want to discuss in details due to the paucity of time. In summary, the viral retinitis is an important cause of sudden visual loss and is an emergency, often an important sign of underlying disease like HIV. Molecular dialogic studies can be of intraocular fluid like PCR can confirm the diagnosis, but phenotype is often characteristics in like acute retinal necrosis, CMV retinitis. May need laser and vitreous surgery in many cases. Rapidly progressing, visual prognosis is often not good. Prompt and proper treatment can only salvage the vision. Thank you very much. Next, I invite Dr. Sudarshan from Shankar Netralaya to talk on a very important topic, many phases of syphilitic uveitis which can masquerade any type of uveitis. Dr. Sudarshan, please.
Good afternoon, everybody. Thanks, Dr. JB, for giving me the opportunity. So we saw different patterns of viral retinitis. So we had a good teaching about retinitis. When you have this classical presentation of a pizza pie appearance, then you call it CMV retinitis. You can have a granular appearance, which can also be CMV retinitis. So then you have this retinitis in the periphery, then ARN, so acute retinal necrosis, where you have a coalesced peripheral lesions. When you have retinal lesions all over, then progressive outer retinal necrosis, which is there in HIV positive patients. So when you have familiar patterns, then you can suggest etiology. A retinitis with peripheral lesions, then you have ARN, all over, then it is PORN. Then you have the retinitis with hemorrhages, CMV retinitis. And the same one, you can have a granular appearance, which can be the granular type of CMV retinitis. But what if you find atypical presentations? So if you are not finding it very typical, not fitting into any of the patterns, then you're probably dealing with something atypical. You need to investigate, do intraocular specimen evaluation. But one important thing that you need to suspect is syphilis. So syphilis as we have always learned that it is one of the greatest imitators. But at least for Indians and in this endemic area, for us anything and everything is probably TB. I mean, other than TB, then if you have posterior retinitis like picture, TB they say never presents as, or almost always presents as choroiditis rather than retinitis. So if you have atypical retinitis or atypical presentations, then you have probably thinking of syphilis. So my topic is many phases of ocular syphilis. So syphilis we thought usually occurs in the tertiary or latent phase. Tertiary phase, almost up to about 5% of the patients of tertiary phase syphilitic patients seem to be getting ocular lesions. But now it seems to occur at any stage. There is no definite correlation with any specific phase of syphilis. It may occur as early as 6 weeks after transmission. Nowadays with HIV co-infection, there is a resurgence definitely, because primary syphilis facilitates HIV transmission, and HIV may modify the natural course of syphilis, and there is an increased risk of getting into neurosyphilis. So what we were talking about atypical presentations, but are there any, if what you call it oxymoron, your characteristic atypical presentations, if there are any, if you can call it like that. So for example, this is one patient, is a 40-year-old male, which presented with diffuse necrotizing retinitis, vitritis, panuveitis, vasculitis, and some choroidal lesions also. There are so many things. If you have so many atypical presentations, the first thing you think of is syphilis. So in this case, you do an intraocular specimen evaluation and actually to rule out toxo or viruses. Then ACTAP in this PCR was negative. RPR TPHA was raised, and this turned out to be HIV positive also. So remember that if you have an atypical presentation, and syphilitic uveitis can be the presenting feature of HIV also. A not known HIV patient, they may look otherwise very healthy. If you have placoid lesions or these atypical diffuse retinitis, one of the things you need to remember is syphilis as a differential diagnosis. So it is not necessarily posterior uveitis. You can have even endophthalmitis like picture. This was a young boy who came with endogenous endoph like picture. And blood culture, obviously, because of endogenous endoph picture as a routine, we did the test, which is negative. ACTAP was negative. So we did vitrectomy with vitreous biopsy. Post vitrectomy, then you found this peripheral retinitis lesion, which was not again typical. So ACTAP, vitreous biopsy, vitreous PCR, everything was negative. So RPR TPHA was positive, turned out to be syphilitic. And after treatment, you get the salt pepper retinopathy, which is how syphilitic retinitis heals. So remember that even an endogenous endoph or a panuveitis like picture can be the first presentation. Even when in doubt, a posterior uveitis atypical or a panuveitis like picture, then you suspect syphilis, especially in the current era. So we treat them with how we treat neurosyphilis. But there has always been in the textbooks that we've read that neurosyphilis you need to do, or ocular syphilis you need to do CSF tap. That may be in the textbook, but practically when we do CSF tap in such a situation like this was a panuveitic patient, ACTAP was negative, but if the patient had some neurological symptoms along with it, or if neuroimaging has some issues, then you do CSF tap, one of these patients which showed raised status. Otherwise, you don't need to do CSF tap in every patient of ocular syphilis. So I've been showing patients where we had treated with antibiotics and then it got okay very well. But is it the case always? Sometimes it is not. We are not so lucky. This was a young male, syphilitic uveitis, treated with penicillin and got okay. We have this localized RP-like picture, salt pepper retinopathy, which is one of the typical features how it resolves. HIV positive patients with improvement in immunity, he started getting vitritis and cystoid macular edema, treated with topical. All HIV patients, you always have the problem of not able to treat with oral steroids fully because of risk of immunosuppression. So when in special situations, you can try intravitreal steroids when there is viral load is low or RPR TPHA is negative. And this is one patient resolved very well with Ozurdex in a patient who had recurrent CME with probably IRU. So it's not always that it infective causes that syphilis mimics. This was a patient which is referred to as Behçet's disease with FFA finding showing fern-like pattern. But then it turned out to be that it was not Behçet's, B51 was negative, no other symptoms, and syphilitic uveitic it was. So it's not always that posterior or panuveitis. You can even get anterior uveitic or panuveitic like picture with anterior segment clues. This was one patient where you had a corneal lesion and along with that atypical retinitis. So look at the corneal lesion. If you have that leash of vessels over there and then retinitis, then you're probably dealing with a case of syphilis. So anterior segment finding can also be a clue as a panuveitic entity involving the sclera or involving the cornea or involving the sclera. This was reported where there is an ocular tumor-like presentation, a scleral nodule, which turned out to be syphilitic. So if we are talking about anterior segment clues, are there any posterior segment clues other than saltpaper retinopathy when it heals? So these precipitates, which are the posterior hyaloid phase or subretinal precipitates, are one thing. If you look at it, if you see this, then these are most probably syphilitic. If you have classical placoid lesions described, then it is syphilitic again. We don't see that often nowadays. In even Donald Gass initially probably thought all these APMPP or serpiginous was syphilitic maybe. But you come to a point, you start thinking that okay, now I found these are the characteristic atypical lesions, but then you are stuck again. Uveitis, that's how it's more interesting every other day. We found this patient where there was HIV patient with this atypical kind of lesion. ACTAP showed PCR MTB positive and RPR TPH was positive. So you had, like, if one is not enough, two is not enough, there are three. So at this stage, how do you decide whether the blood RPR TPHA and the eye lesions are connected to each other? Because you may have an eye lesion, you may have an RPR TPHA, but how do you say they are like both connected to each other? So because ocular syphilis diagnosis is by a positive syphilis serology, and you need to exclude other infectious causes. So you may have multiple infections like the previous case, you can have false positive. Then one option is, obviously when you have PCR treponema, then that's great. But otherwise, one of the options is, because when you do when you suspect neurosyphilis, you do CSF tab and then check for TPHA titers. When you have ocular syphilis, suspect do AC tab and try to do TPHA titers. Vitreous tab the people have tried. We also tried a series of patients with TPHA testing of the aqueous fluid, and we found excellent correlation between the raised aqueous TPHA titers and the serology, and corresponding decrease with the resolution of the lesions. So aqueous TPHA is not the recommendation in every patient, but could potentially be a valuable tool in the diagnosis of ocular syphilis. So we are talking about imaging in everything. So we'll also image in our infectious uveitis patients. So syphilis, the study from Avinash and Mudit, where they've shown that these miliary lesions which they find in syphilis seem to involve the full thickness of retina and may heal with pigmentation. These they feel probably are very classical. So are there any difference between HIV and non-HIV patients? Most probably HIV patients are very, pan-uveitic presentation is more common, but in non-HIV patients, some patients seem to be presenting with retinal vasculitis or vitritis or intermediate uveitis like presentation alone when compared to the non-HIV patients. So to conclude, syphilis seems to occur at any stage. Obviously, it is on the rise, especially in the risk category, like and the group of patients who are MSMs, men having sex with men. That is a risk group. Panuveitis is the commonest presentation. One thing about syphilis is that even though the CD4 counts may be low, they can have significant inflammation despite low CD4 counts. So you need to have both treponemal and non-treponemal tests, CSF imaging in select situations, and treat like neurosyphilis. But always remember that immune recovery uveitis can occur. Repeating what Somshila said, please come. It's going to be an exciting conference. We have the host here sitting with us to come here and invite us, I guess, Dr. Noora here, the president of UCCon. There are exciting travel grants, and it's a long weekend, 29th, 30th, or Friday, Saturday, and Sunday, Monday, October 2nd, Gandhi Jayanti. So you can have exciting uveitis and exciting holiday in Abu Dhabi. And we are from SN. We would like to invite you for the Retina Summit in on 30th June and July 1st. So it's on macular surgeries. So all of you are welcome. Thank you.
Thank you, Dr. Sudarshan, for a wonderful talk on many phases of syphilitic uveitis. You really showed excellent cases with good explanations, and initial photographs of yours is really amazing. So next we come to that another infectious entity which you see quite commonly. I wanted to highlight that what is the atypical as well as the typical cases of toxoplasmic retinochoroiditis, which you used to see much more before. Now we see the TB more common. Typical toxoplasmic retinochoroiditis, typical and atypical cases. And with this topic, I invite Dr. Parthapratim Datta-Majumdar from Shankar Netralaya to deliver the talk on toxoplasmic retinochoroiditis, typical and atypical cases.
Thank you, sir. First of all, I would like to thank my teacher, Dr. Biswas, for having me included in this symposium. So I'll be talking on toxoplasmic retinochoroiditis, typical and atypical cases. So as long as you can see this picture, as long as it presents with this kind of headlight, no fog can cloud the diagnosis toxoplasmosis. You see this kind of picture in your OPD and you realize that without doing any investigation, you can make out that you are dealing with a case of toxoplasmosis. So toxoplasmosis, if you can see, no, it can actually dictate the apoptic response of the infected host cells in the human body. They can decide what the cell will do. So that's why if you see, it is one of the successful parasites on earth infecting a third of global human beings. So its impact is huge because of its mechanism that it dictates that the apoptic component or mechanism of the infected cells. Now, if you see in ophthalmology, the toxoplasmic retinochoroiditis in most of the epidemiological study from the tertiary care center, it is one of the most common cause of infectious posterior uveitis. And if you look into the studies from various across the world, you will see that it can present as a posterior uveitis also and panuveitis also. So now when we talk about typical, it means that there will be a fluffy focal necrotizing retinitis or retinochoroiditis, may be adjacent to the previously pigmented chorioretinal scar and with significant overlying vitritis. So that defines the case of a typical toxoplasma. So I'll show you two cases here. The first case, the 30-year-old female presented with mainly floaters for 20 days and diminution of vision for 10 days. And the patient actually gave history of fever 1 month back. The serology was inclusive. So after following that, she developed the ocular symptoms. So it was suspected as a, because you can see here the patches of retinitis and the hard exudate scattered around the macula, making an incomplete macular star. So that's why the patient was initially suspected as a viral retinitis. The patient was started on antiviral and oral corticosteroid. And on examination, right eye was within normal limit. Left eye had quite SC, but few cells in the anterior vitreous. So, and this was the fundus picture. You can see the minimal hyperemia of the disc. So now if you see carefully, you can see the involvement of the vessels here also. You can see the tiny whitish deposits over the blood vessels and the subretinal fluid over the macula. So with this clinical picture, we started evaluating the patient and we did the fundus fluorescent angiography, which showed the hypofluorescence corresponding to the lesion. And when you can see characteristically the vessels did not leak on fluorescence and there was only leakage of the dye from the margin in the late frame. So when we did OCT, you can see that there are some hyper-reflective deposits over the inner retinal surface and the retrochoroidal space, and the investigation was within normal limit except anti-toxo IgG and IgM was raised. So this patient, when we started with anti-toxo treatment, you see how dramatically it responded, and you see in 3 months the vision became 6/6. So that's how it toxoplasmosis, sometimes you think it as a viral retinitis, and that's how you can manage and give a better outcome. Coming to my second patient, the healthy male of 23 years of age presented with floaters for a month in right eye, and the patient was thought to be a case of acute retinal necrosis. And let me show you the clinical fundus photograph here. And as you can see that there is granular opacity in the extreme periphery and was giving a view of like a kind of maybe the CMV retinitis or acute retinal necrosis. So this patient, I'll just give you a little better view here. You can see that there is an area of healing also here. So this patient, we started investigating the patient, and we found that the IgG was abnormally normal, elevated. The normal, you can see it was more than 20 times raised, and IgM was within normal limit. But we went ahead with our clinical intuition, and the PCR from the aqueous aspirate showed that it was positive for toxoplasma. So similarly, we started treatment with anti-toxoplasma, and you can see here. So this is how the patient responded. Now coming to the atypical toxoplasmic retinitis, let's learn from the lessons from the lessons. So toxoplasma can occur in retinal periphery, number one. Number two, the hemorrhage is uncommon, but as we have seen in first cases can occur. Pigmentary changes can occur little later in the clinical process of healing. And you have to understand that the involvement of the optic disc is a very ancient description given by Janssen. So it is known as Janssen's choroiditis. So what are the three common causes of Janssen's choroiditis? 3T. One is tuberculosis, toxoplasmosis, toxocara. So you have to keep that in mind when you see the peripapillary choroiditis here. The next important is sometimes to confuse you further, the neuroretinitis can have that neuroretinitis like picture with edema of the optic disc. Sometimes sometimes it can present with like macular star appearance. So you have to remember, if you see the peripapillary choroiditis or this kind of neuroretinitis picture, you have to keep the toxoplasmosis in your differentials. Now coming to the retinal vessels involvement, sometimes it gives us a different direction. It can lead to a different direction. So you have to see that these are the segmental involvement in the retinal arteries mainly. So what happens here, there will be migration of the inflammatory exudates and they will be settled over the artery. So when you do fluorescence, it's not a clear cut vasculitis, so it don't leak the fluorescein. So that is a differentiating point due to, secondary to when you do a case of frosted branch angiitis will leak the fluorescein, whereas in toxoplasma, especially in chirolis plaque, it won't leak. Now, chirolis plaque, one of the clinical signs, it's not a telltale sign of toxoplasma. You have to remember there are various other conditions which can, including the Mycobacterium tuberculosis, Treponema pallidum. There are various other causes of chirolis plaque, but most commonly it is associated with toxoplasma retinochoroiditis, especially if you see a retinochoroiditis patch and this kind of vasculitis. Now, as I say, we have seen in our two cases, it can mimic the viral uveitis because both the condition can have high intraocular pressure. There can be associated anterior chamber reactions, and there can be significant reaction in both cases in the vitreous, and especially in toxoplasma, very early stages, because the cysts are lying in the retina, and then the release of the tachyzoid, they starts distracting the retina and then goes deeper into the choroid. So it can mimic in very early stage the viral retinitis. Now you have to be very careful when you are dealing with a toxoplasma in immunocompromised or HIV patients, because they will have a different look. They can mimic any kind of viral lesions, and usually it will be diffuse and very fulminant. Now, just a very quick note on the ancillary investigation. If you read this paper by Alexandro, that in doubtful cases, OCT can be a very useful tool in differentiating the toxoplasma and the viral retinitis. So in toxoplasma, you will see that there will be round deposits along the posterior hyaloid. You can see here, and the mirror images on the retinal surface. Similarly, just you can see here that they will mirror this kind of images. And also another thing, that the toxoplasmosis does not obscure the underlying choroid. You can see here, but whereas in toxoplasma will obscure the underlying the choroid, whereas the viral retinitis won't obscure the underlying choroid. And also you have to understand that the absence of hyperreflective septa within the choroid, so that also defines this. So just last point, and I will conclude my talk, that you have to remember that don't treat this patient only on the basis of serological test, because these are all again ubiquitous organisms. As I said, that it can involve the 2/3 of the global human being. So always go with your clinical judgment, and in doubtful cases, maybe the PCR and other tests may help. Thank you.
Thank you, Dr. Partho, for elegant talk on toxoplasmic retinochoroiditis, depicting the typical and atypical cases. Now we move on to another important infectious uveitis, which is predominant in our country, tubercular posterior uveitis, and to deal with no other than Dr. Vishali Gupta, Professor Vishali Gupta from PGI Chandigarh, who had done seminal work on tubercular posterior uveitis, including the collaborative ocular tuberculosis study. And Dr. Vishali Gupta will be talking on tubercular posterior uveitis, new strategy of diagnosis and treatment. Professor Vishali, please.
Thank you, Dr. Biswas. So, sir gave me a topic of new strategy of diagnosis and treatment. I don't think we have a new strategy. So, let's talk about what are the challenges which you face. As a comprehensive ophthalmologist, it's important to know how to diagnose. But when you diagnose, you believe that it's the end of the challenge, but in fact, it's the beginning of a whole set of new challenges because you are confused when to start therapy, give it a local or systemic, should you give steroids, should you not, and what should be the timing of starting steroids, stopping steroids. So let's go over it one by one. And the question which is most commonly asked is that do you need a internist or a pulmonologist to start treatment? And if you, God forbid, ask them to start treatment, they generally tell you there is no evidence of TB in the body and we will not give treatment. So that is something which very commonly we encounter. So what is the customary uveitis management is, when we deliver it, it may not have lot of variations because we all are trained differently, we all have different practices, we all have different logistics, and TB, I think, tops the list where all these practices and all come into matter. So how do we learn the new strategies that Dr. Biswas told me that what are the new strategies? The problem is we all rely on our training and our training beliefs in uveitis and especially in tuberculosis may be different from one big institute to another. When we go to practice, we go on with whatever knowledge we have acquired, and that's a default emotion. And then we need here a multidisciplinary approach. And sometimes internists always, make to feel you that they are superior to ophthalmologists and they know better than you, and they generally kind of tell you that, well, patient does not need TB treatment. So that is the purpose. I'm just going to tell very briefly what has changed. I'm not going to go over the literature and all. I'm just going to give you the pearls that we have got from our collaborative tuberculosis study group. The most important thing we realized was TB has various manifestations in different part of the world. So if you have a patient coming from another continent or another country, the manifestations may be different. Manifestations would also vary from different state to state. A simple example, Singapore and China does not see much of serpiginous like choroiditis, whereas the Indian continent and the European are very high on serpiginous choroiditis as manifestation of TB. So the clinical presentation could vary from the country of origin. The second thing is, which we realized on various permutations and combinations, is that the basic investigation so far still remain chest imaging, and CT scan is much better than X-ray. X-ray generally does not pick up, CT does. Montius is still the gold standard, especially in a country like ours where it is available. And quantiferon TB Gold, even though it is banned by the government of India for making the diagnosis of pulmonary TB, is still very useful when we are looking at ocular TB. So these are the three investigations that majority of the experts still rely on. PCR is available only in few institutes and it is mostly in-house PCR because the closed loop system gene expert does not really show you very high sensitivity. So don't be concerned that you have to rely on PCR to make the diagnosis. You can be done with very simple basic methods. That is what is new in diagnosis. If you ask me, it's basically what is old, but the same things which were. And maybe Soumya Basu is sitting at the back, so he has this idea that we should have diagnosis based on the clinical features alone. We have not reached there yet, but we may in future, but for the time being, it is the clinical phenotype suggestive of TB, Positive PPD skin test are Monteus, quantiferon TB Gold if you can do, if you can't, even then it's okay, and the chest CT. Important point to remember is that when you are doing chest CT, you are not looking for active pulmonary TB. CORDS data showed that 89% of the patients do not have active disease anywhere in the body. And out of the remaining 11%, those who have, majority may be in the cervical or lymph nodes and not in the lungs. So when we are looking at the CT, it is just to look at some calcified lymph nodes, Gons focus. We are really not looking at active lesions. Now comes treatment. When do you treat? So the treatment would depend on what is your phenotype. For example, in India, it's the serpiginous-like choroiditis, which is one of the most specific presentations of TB. So you would start anti-TB if if all three, PPD, IGRA, and chest imaging is positive. If PPD, IGRA are positive, or even if one of the tests is positive, you will start this patient on anti-TB therapy. Important point to remember is when we start them on therapy, there is going to be paradoxical worsening, which occurs almost in 40% of the patients. And as you see here, this is before you start treatment, and notice these lesions. Once the treatment is started, the paradoxical worsening is characterized by increase in the previous lesions and the development of the new lesions. So now there is paradoxical worsening and the patient is already on ATT and steroids. What would you do? This worsening is due to increase in the cytokines which appear when the ATT starts working. Typically comes in about 2 to 3 weeks time, and this can be managed by giving local steroids, local methotrexate, or increasing systemic steroids. So would you use steroids concomitant? Yes. There is a role of concomitant steroids in the phenotype serpiginous-like choroiditis to prevent paradoxical worsening because it has a high incidence. Patient may not always complain because many a times this worsening happens in the periphery. So in patients where you are not able to take them off corticosteroids, or the disease is progressing despite ATT and you do realize that they are dependent on steroids, steroid sparers can be given. For the other things also, anterior uveitis, we do not recommend starting treatment in the first go, but if you have the recurrences and 2 test positive, it may be started. Intermediate uveitis is difficult to treat and many a times Monteus may be incidentally positive and difficult to manage with ATT alone. So the treatment is only when all the 3 tests are positive. So this is just a very simple. It is available on IOSG website for those of you who want to download. You just enter patient's name, age, gender, country, and whichever eye, and very simple phenotype, like is it choroiditis, whatever it is, it will automatically tell you once you enter the country. And these are the only 3 tests it is asking for. Monteus, IGRA, and chest imaging. It says X-ray, but it is about chest imaging. And then it gives you the result. The result will come like very high probability amongst expert, which means 90% of the experts would consider giving ATT to this patient. So this is a tool which can be very useful for comprehensive ophthalmologists who are trying to figure out to give ATT or not. And with this, I would like to thank Dr. Biswas for the very kind invitation.
Thank you, Dr. Bishali, for giving a very clear, concise idea about the diagnosis of TB and the treatment guideline. And it's really is a very nice, elegant presentation, with which we move to the last presentation. Dr. Manisha Agarwal will be talking about endogenous endophthalmitis, which mimics infectious uveitis often. Dr. Manisha is from Dr. Sharaf's Charity Hospital. He is a vitreoretina and uvea consultant.
So a very good afternoon to all of you, and thank you, Dr. Biswas, for making me a part of this wonderful IC. Endogenous endophthalmitis, don't miss it. So I took a while to understand what exactly JB sir wanted me to speak on. So I thought the best would be to share the experience of dealing with endogenous endophthalmitis with all of you by sharing 2 clinical cases which we managed in our clinic. So this was a young 18-year-old boy from Bihar presenting with gradual painless diminution of vision in the left eye for last 6 months and treated with off and on oral steroids. There was absolutely no significant systemic or contact history, and the child was from a low socioeconomic status. The right eye fundus was absolutely normal and with a vision of 6.6, while the left eye fundus apparently showed subretinal fluid in the macular area extending till the arcade, and you had some kind of a yellowish subretinal lesion which was again very extensive, and it also was accompanied with an hyperemic optic nerve head and a huge pocket of subretinal fluid. When we did an OCT, it showed thickening of the layers of the retina, that it was also involved, and it was just not a subretinal lesion. And this is how it appeared on doing a fundus fluorescein angiography, where we had mottled areas of increased hyperfluorescence within the lesion with diffuse leakage in the late phase, along with a hot disk. So we were quite sure that we were in fact dealing with an inflammatory pathology. We wanted to be sure that we are not dealing with any kind of a masquerade, and we went ahead and did an ultrasound which showed a circumscribed lesion which was quite large over the posterior pole, high surface reflectivity with a homogeneous low to moderate internal reflectivity and with a pocket of subretinal fluid. So the provisional diagnosis, keeping a young boy in mind, we thought we were dealing with subretinal abscess secondary to tuberculosis, which apparently is the most common. And a possibility of other chronic infections also was kept in mind, such as a fungal infection and a lymphoproliferative disorder in this particular age group. So the patient underwent baseline investigations, where to my surprise, the Mantux was a 0, which you do not expect in a young child again. There was a raised ESR, which was suggestive of a chronic infection, and Mantux 0 somewhere conveyed that probably the child was immunocompromised. Chest CT was normal. So we then sent the child to a pediatrician for evaluation, and the history that came out from systemic evaluation was that the child had not been vaccinated with BCG. He was having the slow growth percentile. The child was mentally subnormal. He had some skin infection. The HIV testing, of course, was negative, and the clearance was taken to start this child on systemic steroids because it was involving the macular area. So I was not very sure with what we were dealing with, so I went ahead and I did a vitreous biopsy. And this is something we should really opt for when we are lost with our diagnosis. So you see that a vitreous sample was taken overlying this particular lesion in the macular area. The gram staining came out to be negative. There was no acid-fast bacilli which was isolated. The PCR was negative again for MTB. The culture was awaited, and the treatment, of course, was started with IVMP, followed by oral steroids because it was involving the macular area. After IVMP and after 3 days, the patient looked something like this. Now, the patient started complaining of cough with expectoration, and the sputum was sent for acid-fast bacilli. It did come out positive, but it just showed a single acid-fast bacilli. And the physician was not really ready to start ATT because they were not convinced whether it was a contamination or whether it really suggested an active TB infection. So we started him on oral fluoxetine because this child was from Bihar and was now eager to go back. So we started him on ofloxacin, keeping in mind that it could probably have a role like a second line ATT, and also the child was put on oral steroids. Now the vitreous biopsy, which we had sent, started showing some amount of growth, and it was this creamy white growth which started coming out on the media. Gram-positive filamentous bacilli, they started growing, and this was finally diagnosed to be a nocardia species. The acid-fast staining, the second time when it was repeated, it was negative. The MRI brain was done to rule out intracranial nocardiosis, which again is a very important thing to be done. And the patient was started on sulfamethoxazole and trimethoprim combination, and the oral steroids were continued. After 2 months, the child started responding on this treatment, and you see that there is a beautiful regression of the entire subretinal fluid. So when we reviewed the literature, we realized that this is a rare entity most commonly affecting the choroid, as the spread of this infection is hematogenous. The posterior pole is most commonly affected as the choroid is thicker with more dense capillaries at the posterior pole. And the intracranial involvement is very common, and it's commonly confused with tuberculosis or a fungal infection. So this was indeed a very big learning for all of us, where we had a very unusual type of organism which was causing an endogenous endophthalmitis in this young child, which we had not really expected. So your mind always has to be open that you may be actually dealing with some kind of an underlying infection. Now let me present another case, which is the other side of the coin. So this is a 60 years old male patient presenting with gradual painless progressive diminution of vision in the right eye for last 2 months. There was a history of hypertension, diabetes, CAD, COVID treated with steroids in the past, and diagnosed as fungal endogenous endophthalmitis and treated with pars plana vitrectomy along with oral and intravitreal voriconazole elsewhere. So this patient apparently was carrying these photographs with him, where the right eye apparently had the subretinal yellowish exudation, which was diagnosed as an endogenous endophthalmitis, keeping in mind that the patient had a history of COVID and was on long-term oral steroids. The left eye apparently was quite normal. And the microbiology and cytological samples showed that there were no fungal elements. Lymphoid cells with irregular nuclei apparently were seen. So this is how the patient presented to us. The vision was 6/9 N10 in the right eye. You have this extensive lesion, which again is very typical if we know the diagnosis. It's like a spot diagnosis. And this is how the left eye was. This is the right eye OCT, where you see this huge bump in the area where that yellowish lesion was present. And you also appreciate the ragged appearance of the RP with some amount of deposit under the RP. We also had a similar kind of bump even in the left eye, right in the subfoveal area. So here we are dealing with a patient diagnosed as endogenous endophthalmitis, query fungal, secondary to the history that the patient gave, but came out to be a primary vitreoretinal lymphoma. And we did go ahead and did a revitrectomy for this patient with a subretinal biopsy, because already there was a diagnosis that had been made for this patient. So here we have, I've gone ahead, I've made a small opening at the edge of this particular lesion. And finally, this exudative material was taken out from the subretinal space. I think the video is not working, and it was subjected again to the cytology and to the other investigations. Now, on H&E stain, it showed large and small lymphoid cells in a background of necrotic cells. The patient was suggested to undergo a mid-88 to confirm a PVRL. A PET scan and MRI brain was done, which was again normal for this particular patient. The patient did undergo multiple intravitreal injections of methotrexate, which were biweekly started. And this is the timeline of the patient, where you find that the patient has responded beautifully to the intravitreal methotrexate injections which were given in the right eye. And this is the left eye, where again we find that the patient has really responded. We also subjected the aqueous humor sample to IL-10 and IL-6, and apparently after having undergone the treatment, the IL-10 was not detected, which showed that the patient had responded beautifully to the treatment. So I would just conclude my talk by saying that endophthalmitis, even without a recent history of surgery or trauma, please suspect endogenous endophthalmitis. A detailed history to locate the foci of infection is extremely important. More posterior segment signs are apparently present when you are dealing with a patient of endogenous endophthalmitis. A vitreous sample with blood and urine samples is extremely important again to locate the foci of infection. And always remember to rule out any underlying masquerade which can probably be misdiagnosed as an endogenous endophthalmitis, like in my second case, because of the strong history of COVID and being on long-term steroids. So thank you so much for your patient listening.
Thank you, Dr. Manisha, for giving me that cases of endogenous endophthalmitis, very thought-provoking cases. With this, we finish the talks now. Dr. Mamta Agrawal is not there. We have got about 10 minutes time for question and answers, 12 minutes time. We have got, I just like to ask Dr. Sudarshan, one of the cases where you don't order syphilis test, where you do not order syphilis test, or what infectious uveitis, when you say that syphilis test is not required.
So,
So
currently acting at the Sun 2 classification wise, like every uveitis case, they suggested to add syphilis as an etiology. But otherwise, if you have a classical CMV retinitis like picture or an ARN, probably those are the situations where you don't do syphilitic tests.
sure, that's the take-home points. I just like to ask Dr. Vishali, there are a lot of cases I see from the records.
So he's
That-
asking which is the confirmatory test for syphilis. There is a question.
Okay.
Okay, so that's what, like, unless if you have a CS from the organ, that was one of the reasons we did that AC tap or we test sample. Some people have studied to test for the titers from the organ of involvement. Okay, that is, but most of the time is the correlation between the titers and the ocular lesion. PCR trypanemia is there, but they have not found out all the genomes in it. But sometimes it is sensitive enough.
Any other question from the audience? I just like to ask Dr. Bishali one question, that a lot of times I am seeing that from the records that the patients are given injection Ojudex for serpiginous choroiditis, even Mantu quantiferon positive. I see there is a good response. Do you advocate this kind of treatment?
Yes, we do not really mind because the bacteria are not really actively multiplying there. It's more of an immunogenic response. So sometimes what happens, the lesion is very close to the fovea, and quantiferon typically takes more than a week the result to come back. CT chest takes time, the Monteus takes 72 hours, and you don't want it to come under the fovea. In those instances, we ourselves also, under our supervision, we do add local steroids, Ozitex, or give systemic if you're not too sure, and then add ATT when the results become available.
Do you have experience of giving intravitreal moxifloxacin now?
Moxiflox is not for immune-mediated mechanism of TB. That is only where the bacteria are multiply proliferating and producing an abscess kind of a lesion. So it works really well, but along with anti-VEGF. Moxi on its own doesn't have much role. It's along with anti-VEGF because Soumya's work also and Dr. Rao's work has shown that TB granulomas are VEGF driven. So anti-VEGF per se cut off the supply for the granuloma, and addition of Moxi is another anti-TB drug being given intravitreally, which acts locally. But to give it as the only form of therapy for ocular TB, I think we do not know, but it might be making sense. If there is no TB elsewhere in the body, and if it's only in the ocular, can we treat it just local? We do not know as yet.
I just like to ask Dr. Partho one question. In case of anterior uveitis like KPs, have you seen that presentation with KPs as a toxoplasmic retinitis, as the initial presentation with multiple KPs?
Yeah, I don't think that from the KPs we can differentiate toxoplasma. This thing, it'll
So, initial presentation KPs with lot of vitreous.
yeah, rather
cells.
anterior uveitis due to viral uveitis can have like diffusely distributed KPs, but in toxoplasma, I don't want to comment or think that that from the KPs you can make out the diagnosis.
Any questions from the audience?
anterior viral uveitis, how long we continue the antiviral drugs?
Anterior viral uveitis?
With the corneal involvement, how long we to continue the antiviral drug
Yeah,
systemic?
nobody knows about that. The clinical response is the most important. So actually, I continue for 90 days minimum.
Is there something to like continue? Sometimes we have seen the patients with the prescription for 1 year, they put on something like AIOC for 1 year or something.
So this, what happens actually, the acyclovir is a virustatic drug. So it only acts on the actively replicating viruses. It has no role on dormant or the latent viruses. So that's why we recommend that you should continue acyclovir or antiviral drug for a longer period. Now this is a very ill-defined period that when we tell that you should continue it for longer duration. Means as long as you have activity or you are getting a recurrence of the inflammation or infection, then you have to continue the drug.
Okay.
CME, why the endothelial cell count disease? Because of the affinity of the virus to endothelium is more compared to other virus, or
No, no.
some of the presentation, like in this presentation, they told the CME there is a lot of endothelial cell loss compared to other
Yeah.
HSV and zoster virus.
I'm not sure.
Oh. Is it due to virus has specific affinity for corneal endothelium?
With this, we conclude the session. We have got an excellent session. I'd like to thank all the speakers for the support and the audience for patient hearing. Should we take a photograph? Can I request everybody to come, speakers to come?